First of all, to give you the background or rationale for this project, we are building on the rationale that over 2.6 million people were affected with HIV during the 2009, and majority being in sub-Saharan Africa. We are trying to observe that there is no single, HIV prevention strategy that is acting like a magic bullet to wipe out the HIV epidemic, and therefore we are trying to bring together a number of HIV combination, prevention, packages. We are trying to build on the experiences and success of the home-based HIV counseling and testing project, which we implemented previously, and we are trying to say that it can dramatically increase the knowledge of HIV status, and it's a good entry into combination prevention. In this study, which is Prevention RX, we are saying that a combination prevention protocol based around HBHCT developed by University of Washington, that is the university that supports this project, through ECOBI, which is the local NGO at Kaboy, and we are glad with Johns Hopkins University that supports us technically with the innovation or the mobile health. The Prevention RX provides prevention prescriptions. It is so smart, as he was explaining, that it gives that kind of prevention prescription. Once you correct your data and enter it, it will guide you. You will not have errors if you are correcting data like on Henry. You will not have issues like antenatal, female, so on. So it will give you it will guide you to enter the right data, to give the appropriate referrals, risk assessment, and then track the uptake among the high-risk, individuals and couples. That's why we are trying to target on the high-risk couples, and we are looking at discordant couples. We are looking at high-risk men for HIV counseling and testing, and then we give the appropriate referrals that involve HIV care and male circumcision. What was the start of the goal? We believe that we could implement the home-based HCT and then incorporate the aspect of mobile health through the Prevention RX using the software, which is eMOCHA. In terms of objectives, we had set out to visit 1,000 households, test the feasibility and acceptability of the electronic data capture and the generation of real-time Prevention RX using the eMOCHA developed by Johns Hopkins University, test the Prevention RX protocol effectiveness in facilitating appropriate referral for HIV/AIDS care, and test the effectiveness or its protocol effectiveness in facilitating referral for male circumcision. This is an example of a health worker who is in the household, doing the HIV testing, drawing blood, and afterwards he's entering data through or using the eMOCHA technology in the smartphone. And that's what I was mentioning, that it is telling him to confirm whether the patient who is, this stands for the first surname, and that is the age, which is 67, and is a male, and the technology is prompting the health worker to enter the right data back or key select, so that he doesn't enter any wrong data. We are trying to share with you some of the preliminary results. Between November 2010 and April 2011, a team of only 3 health workers or counselors that visited the same urban area in southwestern Uganda within just a period of 4 months. They had managed to visit 855 households, and out of those they tested 1,558 participants and referred 152 HIV positive adults, and out of those total tested 123 were referred for male circumcision, and the total number of follow-up visits were 572. This is just a small illustration of how mobile health works. Within a period of 4 months, having only 3 health workers, you can manage to reach out all these almost 1,000 households and almost 2,000 adults. You see how it is amazing. In terms of field experiences with eMOCHA or that kind of technology, the Android phones and eMOCHA have worked very smoothly. We have not had any technological, breakdown. There is no single day we have missed working. We are spending less than the anticipated time in data collection, so it's so fast. For instance, we had thought each health worker would be testing only 6 participants per day, but at the end of the day, we are seeing them doubling the number from 10 to 12 participants per day. The technology has been well received at the community level. We have not had any complaint from any community member. Their main target is receiving the service. We are doing a lot of we are seeing a lot of savings in terms of costs because we don't have to hire the extra staff for data entry, and hire the huge stores, procure papers and pens and so on. In terms of recommendation, or if I was to summarize, eMOCHA is proving to be very effective and efficient in mobile data collection system and management, and therefore various players in health field need to embrace it, welcome that technology, so as cut costs and save resources to other appropriate areas like prevention and treatment. We are very thankful to all those teams from Johns Hopkins University, from University of Washington, from ICOBI, Imperial College London, that provided technical guidance and developed the protocol, and of course the NIH or U.S. National Institute of Health for multiple package program funding, and of course thank iheed for the invitation, because we had not had the opportunity to come together as different, implementers of mHealth technology. We were working in isolation and, independently. So we are sharing a lot and learning very much from each other. And thank you all. Thank you.